Now I would like to introduce our next speaker, Dr. Partha Ghosh. Excuse me. He is a pediatric neurologist specializing in neuromuscular disorders at Boston's Children's Hospital. After his medical school in India, he completed a pediatrics residency and adult neurology fellowship at the Postgraduate Institute of Medical Education and Research. In order to pursue further training in pediatric neurology, he came to the U.S. He's then completed a pediatrics residency and child neurology fellowship at Cleveland Clinic, followed by fellowships in neuromuscular disorders and clinical neurophysiology at the Mayo Clinic. He is currently an assistant professor of neurology at Harvard Medical School. At Boston's Children's Hospital, he directs the EMG laboratory and co-directs the MDA Care Center. He has received the Outstanding Teacher Award in Pediatric Neurology as recognition of teaching residents and fellows at Boston's Children's Hospital, and serves on the editorial board of Pediatric Neurology and is the associate editor of the Orphanet Journal of Rare Disease. Dr. Ghosh, thank you for being here today. I will turn it over to you.
Thank you. And let's share my screen. Everyone, we'll be talking about the role of research in pediatric neuromuscular disorders, the current and the new treatments on the horizon. Since I am a clinician, I would be focusing more in terms of the clinical research and the clinical trials. And basically, these are my disclosures. We are basically discussing more about the, since neuromuscular disorders are a huge topic, we would be focusing about two very common neuromuscular disorder which we see in the pediatric neuromuscular clinic, about spinal muscular atrophy and Duchenne muscular dystrophy, and the role how the research has changed the landscape of treatment in the last couple of decades, and what we have approved therapies now and what we have in the horizon. And then we'll briefly talk about some of other neuromuscular disorders, mainly focusing on certain muscular dystrophies and Pompe disease. So first, talking about spinal muscular atrophy, the first description was about in 1890s, and about a century later, we have the current clinical classification which we use for in the diagnosis and of the SMA clinically. Now, we used to define SMA in three broad clinical types in children based on their functional motor skills. So type 1, as you know, is in children where they are not able to sit. Type 2 is usually whether they are able to sit but not able to walk. And type 3 is they're able to walk. So typically the age of presentation, type 1 is below, before 6 months. Type 2 is between 6 to 18 months, and type 3 is after 18 months. Now that's what we learned, and that's what we have been trying to classify SMA. But as you all know, with the advent of newborn screening and the introduction of therapies in the very early in the stages, this classification has changed, and in the next coming few years there would be probably a newer form of some classification which we need to use. The other thing which has come up is a role of a modifier gene or SMN2 copy numbers. As we know that more severe the disease, less are the SMN2 copy numbers, meaning more SMN2 genes you have, it seems to protect the phenotype or the severity of the disease. So classically in type 1 disease, you have 2 SMN2 copy numbers. For type 2, you have 3, and type 4, you have type 3, you have 4 or sometimes more. So that's basically what we typically see. Obviously, there are exceptions. So in the current clinical classification and algorithms for treatment, you need to involve the SMN2 copy numbers. Now, in the last 3 decades, last decade or so, there has been a tremendous improvement in the clinical trials, and that led to the generation of FDA approval of 3 currently approved therapies in SMA, which we'll talk in the subsequent slide. So this is an algorithm which tells about the treatment decision which we make based on the newborn screening. Now, newborn screening is currently, as of August of 2020, was approved in 32 US states, which accounts for about 68% of all the babies born in US. Ideally, after we know that the screen is positive, we would like to see the baby and discuss with the families about the treatment options. Within the first 2 months of life, our treatment options are nusinersen and the gene therapy. Now, after we get the newborn screening, we want to confirm this by a confirmatory test and know about the SMN2 copy numbers. And then we may need to do some additional labs if the families opt for gene treatment. So as you would see that if you have SMN2 copy numbers, if you have 2 and 3, you are predicted to have type 1 or type 2 disease, and usually there is no confusion. You recommend treatment. Some confusion appears when it's type 2, when the copy numbers are 4 or more. That's predicted to be type 3 or type 4 type of SMA. And in the past, in 2018, when the consensus expert panel recommended treatment in the pre-symptomatic babies, it was thought that if you may wait till they have symptoms, but those have been changed, and in 2020 summer it has been upgraded, and they say that you would recommend treatment for patients who have type SMN2 copy numbers of 4 or more. So that's where basically a patient who is, or a baby with newborn screen positive, you basically get treatment accordingly. So coming to the next slide. So this is basically a diagram, schematic diagram, which talks about the different forms of treatments which we can try in SMA, which we all know SMN-targeted therapies, which include the gene replacement, and we'll talk about it subsequently, and then SMN2 splice modulating therapies, which involves the antisense oligonucleotides or the nusinersen, and then the small molecules as risdiplam. Now, those 3 therapies are all FDA approved, but there are other therapies which can be, which were in clinical trials in the past, and some would be in the clinical trials subsequently. Then there is another group of treatment options where it is called SMN-independent therapies, meaning it acts on different parts of the pathophysiology of the disease, where, as you could see, this is a neuron or a presynaptic neuron, where there are different structures, the cytoskeleton, ribosome, and mitochondria, and different molecules can act on those things and can modify the disease state. One of them, which is currently in clinical trial, of which you may be aware, is something called myostatin inhibitor. A phase 2 trial goes by the name of TOPAZ in type 2 and type 3 patients, where the patients are given IV infusions every 4 weeks. And the interim data showed some positive results. So we are hopeful that this can be added in addition to the SMN-directed therapies to have an adjunctive and combined effect on the treatment. So coming to the antisense oligonucleotides, these are synthetic chain of short chains of nucleotides. There are different types, and based on the modifications of the sugar on the phosphate compounds. Or there are different designs based on the types. So one is gap mud design, another is splice modulating design. We would be focusing more on the splice modulating design, and that's where we have nusinersen and eteplirsen, which is used in DMD. And this is a schematic diagram which tells or shows how the different agents work, particularly for nusinersen. What it does, it helps into introduction of exon 7 into the mRNA transcript so that it leads to the generation of a functional protein product. Normally, this is in SMN2 copy, SMN2 gene, because of a change in the nucleotide, you cannot see that that is not included. Exon 7 is not included in the transcript, and that's why there is about 10% functional protein. So if we use the nusinersen, that helps in the inclusion of the exon, and that leads to the generation of increased SMN2 protein product. So that's sort of the principle of using nusinersen in SMA. So here it's in more detail where you would see normally what I was talking about is exon 7 is normally not included in the final transcript. So that's why the SMN protein is unstable and rapidly degraded. Whenever the nusinersen binds to this site, it removes the inhibition of this heterogeneous nuclear RNA1 protein, and that facilitates the splicing mechanism, which leads to inclusion of exon 7 within the functional product. And that's where, and the mRNA transcript, which leads to the generation of fully functional SMN protein. So this has led to the ultimately the pivotal trials in nusinersen. The two trials are ENDEAR and CHERRY study. Both are intrathecal nusinersen versus sham intervention in type 1 and type 2 studies. And both of them have shown a significant functional benefit. And that is important because that predicts that these children would achieve a better functional goal than expected from the natural controls or the natural history controls, which we know from the historic data. And that has been a major part of improvement, this generation of a lot of data from historical controls, as well as developing these functional skills, because these are basically act as our guide to determine whether intervention or a medication is working or not. And both these trials have shown that these have been very effective, and that led to the FDA approval, which we'll talk in the subsequent slides. Now, these are other studies where they looked into the basically on the asymptomatic or oligosymptomatic or whatever you want to call pre-symptomatic SMA babies, where they would use it as soon as possible after birth when we know the diagnosis. Now they have used it in 15 babies who are predicted to be type 1, meaning that they have SMN2 copy numbers of 2, and 10 type 2 babies who have SMN2 copy numbers of 3. And all of them has shown a significant improvement in their significant improvement in their motor functional skills. And if you look at the final data, it says that 23 out of 25, that is 92%, are able to sit without support. Now, able to sit without support, meaning that they are already transforming to type 2 box, meaning they are changing from natural history of type 1 patients who were not able to sit, they're transforming into type 2. So with the treatment, you are changing how the clinical classification we used to think about about these SMA babies. And similarly, about 88% were able to achieve walking independently, meaning that they are be at least type 3 and better than that. Now, those are this trial led to the recommendation of using the nusinersen and subsequently other SMA therapies for using in asymptomatic babies. That's the sort of the basic rationale for using these therapies. So nusinersen was, as you know, is FDA approved. Its recommended dose is 12 milligram or 5-able intrathecally, given as 4 loading doses, and then subsequently every 4 months. We need to monitor platelet count and coagulation profile, urinary protein, but on our clinical experience, we don't see that significantly affecting or altering the course, and we haven't stopped treatment in any patients because of those problems. Sometimes it's a very, very rare complication of hydrocephalus has been seen in about 5 cases in the post-marketing setting. But again, the real mechanism is not very clear, but we should be careful about any babies who, or any patients who develops any signs of raised intracranial pressure from hydrocephalus should be monitored. Now, what are the future directions in regards to nusinersen treatment? We know that it has good long-term efficacy and safety data, but there are challenges in delivering this intrathecal infusions, particularly in older type 2 and type 3 patients who have severe kyphoscoliosis and previous fusion surgery of the spine. So can we improve on that by increasing the dose of the frequency? And that basically is looked after into the DEVOTE study, where they would be using higher doses and in a more frequent interval in terms of the loading, and subsequently every 4 months. Can we do some other biomarker studies? And one of this is neurofilament. So since these babies are getting CSF studies during their as they're getting the spinal injections, you can check these biomarkers and determine who may need a higher dose or lower dose or how frequent. So it can be a potential therapeutic benefit as a biomarker in subsequent studies. And is there a role of combination treatment? By combination treatment, we mean there is this response study where they would be looking at the outcome, safety, and tolerability in patients who had previously received gene therapy, and whether if you use nusinersen in those babies, whether that would be of added benefit or advantage, and how they're able to tolerate that things. So there is a lot of directions to go in that regard. Now, coming to the genetic strategies used in gene therapy. So you can use and add a gene to produce functional protein. You can knock down a gene so that you do not want to have the undesirable protein, or you can do some genomic editing, and which could be a hot topic in the subsequent years because of the advent of CRISPR technology. So gene therapy can be delivered in one of the 2 ways. Either it is ex vivo, meaning you take cells from the body, isolate from the patient, and then after it's genetically corrected, it's infused into the patient, and then these cultured cells were therapeutically transduced, and then you put it back to the patient. Now, those are mainly helpful for hematological and immunological disorders where the blood cells replicate a lot. But in neurological diseases, particularly neuromuscular diseases, we prefer in vivo therapy, where the nerve cells are basically non-replicating and the muscle cells are very slowly replicating. So basically, we prefer in vivo therapy, meaning the genetic therapy is infused in the patient and we see the desirable effect there. Now, the core of gene therapy is you have to have a viral vector. So there are different forms of viral vector which can be used, but the one which is approved and licensed for clinical use in neurological disorder is adeno-associated virus or AAV. There are several advantages of that. It has a very low risk of human pathogenicity. It doesn't integrate with the host genome. The target cell population could be both mitotic and the quiescent cells, which is particularly suited for neuromuscular disorder. And the transgene expression is for a long duration in those cells. So because of all these desirable factors, adeno-associated viral vector is an important gene vector suited for the gene therapy trials. And this cartoon basically describes sort of the basic principles of how the gene therapy works in vivo. So here you have the transgene, which is your desired gene. So for example, SMA, it would be the SMN1 gene. You have a promoter which facilitates or guides the transgene into the areas of interest of the desirable tissues. So for SMA, it would be have facilitated the expression of the gene in the brain and the spinal cord neurons. And then you have a poly-A tail which helps in the stabilization of transgene. So all this is the sort of the cassette which goes into the viral vector, and then the viral vector through receptor gets into the cells, and then the transgene sort of produces the functional protein, and where it would have this desirable impact. So this is sort of the principle for all single gene treatments for monogenic disorders using the viral vector, whether it's SMA or spinal Duchenne muscular dystrophy or other forms of muscular dystrophies like limb-girdle muscular dystrophy. Now, in the gene therapy trial in SMA, the pivotal trial was AVEXIS 101, where they used this low and high doses in type 1 babies. And again, they have seen a significant improvement in the functional scales. But one thing which was noted that significant elevation of the liver enzymes happen, you typically within a week after the infusion, and that led to the use in the protocol of prednisone, which is started a day before it's given. Now, those trials subsequent, it would be the STRIPE trial, which is used in the it's basically phase 3 trial on type 1 babies, showed the similar very good results with functional improvement. Then you have the SPRINT study, which is basically on the pre-symptomatic babies. And that again is the rationale for using this gene therapy trial in pre-symptomatic babies. And currently the trial, there is another trial, which is a STRONG study, which is on type 2 patients, where it's given as intrathecal injection. The thought process is if you give intrathecal injection, it would deliver less amount of drug. So higher amount of viral load in the patient can cause a lot of problems, particularly with the hepatic dysfunction. So that's where this study is looking into in older patients. So currently we know the gene therapy is in SMA patients are approved for patients less than 2 years. We do not know for sure the efficacy in very advanced SMA, particularly when there is a complete paralysis of the limb or ventilator dependence, meaning more than 16 hours a day. The recommended dose is 1.1 into 10 to the power 14 vector genomes. It is administered IV over an hour. Now, before starting gene therapy, you need to check those antibodies. And if the antibodies are high titers, they would neutralize the gene therapy. So you have to be careful about that. And that's a prerequisite for the before you start gene therapy. You need to very closely monitor the liver functions, platelet counts, and some cardiac monitoring. And as I described that you need to use prednisone before the starting the treatment, and it's continued at least for 30 days and maybe for 2 to 3 months, depending upon how the child is doing in terms of the liver enzyme numbers. So other considerations, particularly for the caregivers in the first 4 to 6 weeks, because of the risk of viral shedding, they should take adequate precautions. Breastfeeding was initially restricted in phase 1 study, but subsequently the risk-benefit ratio needs to be dependent upon the individual case. Future directions are important. Particularly, we know that it's pretty effective and has been good data about 5+ years, but whether it would be good for 15 or more years, that we don't know. And there are challenges of multiple doses, because if your already immune system recognizes the AAV9 vector, then it would neutralize it, and that would not make it effective. So how we can circumvent that, that's important. Family commitment is very important, particularly in the days of COVID. They need to come to the hospital or lab to get repeated lab checks in the first 2 to 3 months after treatment. And are there ways we can improve on the therapies? And again, the role of combination therapy comes into this picture. We'll briefly talk about the oral splicing modulating agent. So this is what we use is risdiplam. The studies are main goes by the suffix of fish. So firefish for type 1, for sunfish for type 2 and 3, and similarly jewelfish for patients who are older, and rainbow fish looking at the asymptomatic babies. Both sunfish and firefish have shown improvement in their functional scores, and that led to the FDA approval. This is the latest drug which is FDA approved in SMA. It's used only in patients 2 months and older, and that's why it cannot be used at the current stage in patients who are just diagnosed in the by newborn screening in the first few weeks of life. And it may be particularly suited for older patients who have significant difficulty in delivering the intrathecal injections because of severe scoliosis or spinal fusion. So as we have evolved in the SMA therapy, we know that the more we can use it early, it's better, because then it leads to a reversible loss of function. We are sort of delivering the treatment just after birth with newborn screening in most of the cases. But can we improve that by doing in utero treatment? Obviously, this is a hot topic, and we just don't have data to show that whether that would be effective with all other ethical challenges. And similarly, the role of combination therapies and SMA-independent therapies, we would need to look into this in the subsequent years. Now, switching gears to the DMD, as you know, this is the most common muscular dystrophy. Typically, patients present between first to 5 years of life with gross motor delay, calf hypertrophy, very high CKs. And in the natural history in the steroid, before if the patients do not receive steroid, then typically they would lose ambulation by to 13 years. But this has changed with the introduction of steroids as a standard of care in DMD, and with the improvement of the multidisciplinary care, and with the improvement of cardiac and respiratory care, we are seeing patients with DMD surviving up to the 4th decade and more. Importance, we'll talk about a little bit about the genetics of the DMD. As you could see, the vast majority of the patients with DMD, the main problem is deletion of 1 or more exons. The DMD is a huge gene with 79 different exons, as you could see by the numbers. And here, basically, you see a loss of an exon, which leads to a breakpoint. Similarly, there is an additional exon or duplications. These are the most 2 common forms of mutations in DMD. and that leads to what we would show in the subsequent slides as reading frame disruption, and then leads to less production of the dystrophin protein. Others are small mutations. 10% could be nonsense mutation, and there are other different types. So this diagram is important, as you could see that if there is a mutation, this leads to, after the rearrangement, when the final mRNA is formed after splicing, there is a breakpoint. So that's called the disruption of the reading frame. And if the reading frame is disrupted, it is no functional protein is generated. And if you do not have functional protein, your manifestations would be severe, and that's why you present the patients have DMD. Now, on the other hand, in Baker muscular dystrophy, which is a milder form of the disease, you could see that after splicing, though the protein is different, or the mRNA is different than the normal person, but still the reading frame is restored, and hence there is production of partially functional protein, and that impacts the phenotype, meaning they have some protein which facilitate the weakness, or basically make them less weaker. And this sort of sometimes forms the basis of and this hypothesis, and using different products. One is antisense oligonucleotide, where you would be able to incorporate or skip an exon so that the neighboring exons align with each other, producing the restoration of the reading frame, and hence it's sort of as if you are changing the disease from DMD to BMD, so that you have functional protein. And this is a schematic diagram of the dystrophin protein, which is a huge protein. And as you could see, there are different domains. The important domains are the amino terminal domain, which binds to the actin filaments, which helps in the contraction of the muscle. And here you see this repeating units. This is the rod domain, which connects with basically the amino terminal with carboxy terminal and the cysteine-rich domain. And this domain is important because it facilitates the binding to the other proteins within the muscle membrane and proteins outside the muscle membrane. So acting as a bridge between a connection between the extracellular proteins, which is outside the muscle membrane, to the intracellular protein, which is inside the muscle membrane. So if you have a disruption of this protein, this framework is disrupted, leading to breakdown of the muscle membrane, and that leads to the pathophysiology of the muscular dystrophy. Now, I would mainly focus about the dystrophin protein function restoration trials, which has been taking place, and a couple of them has FDA approval. So one is exon skipping. Now, as we know that the majority of the mutations are due to deletions or duplications, it is thought that maybe up to 80% could be amenable to some form of them. Though in the current clinical scenario, what is FDA approved, we have only FDA approval for exon skipping 51 and 53, which accounts for about 23 to 25% of all DMD patients. Then you have nonsense mediated suppression, which accounts for 10 to 15% of the mutations. And finally, gene transfer therapy, which would be great because it is irrespective of the mutation type. So here is a cartoon describing how the exon skipping works. So as you see the mutation, and if you skip exon, then and subsequently in this process of mRNA splicing, you would see that these adjoining exons, they are restored, and they are falling in place so that the reading frame is restored, and hence there is production of functional protein. So it's not a complete cure, but helps in modifying the phenotype, as I described, as if we are trying to create a change from the DMD, which is the more severe phenotype, to a milder or BMD, with the production of some functional protein. The first trial on exon Ds or eteplirsen was got accelerated FDA approval in 2016 based on increase in the number of dystrophin positive fibers and improvement in some functional scales, which is 6-minute walk distance. It is given as IV infusions, generally well tolerated, and longer term studies have shown that there is stabilization of motor function, there is improvement or stabilization of not only the lower limb function, but when the patients get older, there is some improvement in the upper limb or stabilization of upper limb function, as well as it prevents the rapid decline of the pulmonary function. So it has a role in older patients and continuing therapy, so gives the rationale for using continuation of the therapy. Other FDA-approved exon skipping therapy is golodirsen, which goes by Vyondys 53, which accounts to about 10% of the patients. Now, about 2% of the patients who have deletion of exon 52, they are amenable to either 51 or 53 therapy. Another FDA-approved medication in this category is viltolarsen or Viltepso, which got FDA approval in August of 2020. So you have two drugs which are FDA approved for patients who are amenable to exon skipping 53. And casimersen is exon skipping 45. It's currently in the final phases of FDA approval. So combining all of them, you would anticipate if casimersen or exon skipping 45 is approved this year, it would account to exon skipping amenable therapy in about 30 to 33% of all DMD patients. Now, nonsense mediated suppression is a mechanism where if there is a point mutation, it prevents it forms a stop codon, and stop codon prevents the basically subsequent transcription and leads to the truncated or non-functional protein. So if we have a strategy so we can circumvent that, that would produce functional proteins. And the agent which has been used and found to be safe in humans is ataluren. A phase 2 study has shown an improvement in the dystrophin expression on the muscle biopsy, which led to its approval in Europe. However, a phase 3 study did not show functional benefit on all patients. So that's why it's not FDA approved in US. But they have been trying other studies to see if they could have better data which can lead to FDA approval. So unfortunately, we cannot get this medicine used in our patients in US, but we do sometimes see some international patients who are on this medication. Now, coming finally to the gene therapy. So as I have seen, shown in the SMA, if you can replace the gene in a viral vector, that would be ideal. But the problem with the dystrophin gene, because it's such a large gene, it just cannot be packaged into the AAV vector, which is commonly used for the gene therapy trials. So how can we circumvent that? We can use concept of micro or mini dystrophin, and that concept came because a patient with Baker muscular dystrophy who was able to walk after age 60, and it has been found that he has a deletion of exons 17 to 48. So a huge amount of DNA, even if it was not functioning, still the protein was functioning. So that is basically the concept for creating this microdystrophin, where you can maintain certain critical portions of the dystrophin gene so that it can still function by sacrificing some non-functional areas of the gene. So these are sort of this gene microdystrophin constructs. And as you could see, similar to the concept of the SMA gene therapy, you have a transgene, which is this portion, you have a promoter which basically facilitates or drives the expression into the desired tissue. And as you see that the common theme in all this microdystrophin construction, the amino terminal portion, which is the one which connects to the contractile elements in our muscle cell or the actin. Then you have carboxy terminal and the cysteine rich domain, which is the end of the protein on the tail end, where it connects to the muscle membrane and extracellular protein. So these are a common feature in all of them. Now, in this R1 to R24, there are 24 units, but you'd see that majority are missing. So that's the portion where you are sacrificing to produce these constructs of microdystrophin, to have these smaller molecules which can still be packaged, genes which can be still packaged in the AAV vector and can be used for gene therapy trials. So these early trials have shown encouraging results with reduction of creatine kinase, significant expression of the dystrophin on the muscle biopsies, and some functional improvement. And we are awaiting, or we are hoping to initiate the phase 3 trials, which obviously would be the most important to see whether it works in a bigger population in a very controlled fashion. And if that's the case, then this would be an important sort of therapeutic advance in patients of DMD, which we have been looking for a long time. Again, with all the gene therapy trials, your concern is how long it will last, whether there would be the need for redosing, other side effects associated with the gene therapy, and could there be problematic in the long term in the host, meaning the child, in terms of other things, say for example, integration in the host to produce mutagenesis or cancer risk and those kind of things. Now, a brief word about the CRISPR or Cas9, and this technology basically uses this endonuclease is called Cas9, which can clip the genome in a. So it's basically a molecular Caesar, which clips the desired portion in the gene, and then you use the RNA, guide RNA, which facilitates this repair, and that helps in editing the genome. So it can be used for a different number of mutations, whether single exon or multi-exons, and can be virtually used for all DMD patients. And this would be a game changer in the coming few years if it has been shown to be very effective in animal models, which already there has been good results, but subsequently needs to be trialed in the human population. So finally, I'll talk about very briefly about other neuromuscular disorders, not all of them, but one is Pompe disease, where we have definite treatment available. It's an autosomal recessive disorder. Patients typically present with low muscle tone and muscle weakness, in addition, significant cardiac involvement, liver problems. They are diagnosed by testing this acid alpha glucosidase enzyme activity. In the past, it used to be the skin fibroblast or muscle, but you can do it on the blood spot, and the newborn screening is in effect in about 20 states. So that's where you can diagnose these children before they are having significant symptoms. If you have a complete deficiency, you have infantile onset disease, which is very severe, but you have, if you have certain amount of gene or certain amount of the protein, that leads to late onset disease, where patients typically present in their young adult life, or even in the late adult life. So molecular genetic testing helps to confirm on this diagnosis. This myozyme is approved for treatment in infantile disease. It has shown a significant improvement in the survival, reversal of cardiomyopathy, and the children are able to walk independently. And this lumizyme is used for late onset disease, because it can, it's basically for late onset disease, meaning for young adults or adults at different stages. And the new generation therapies would be enzyme replacement techniques, different modifications, and also gene therapy. Now, the other things which are in clinical trials are a group of muscular dystrophy called limb girdle muscular dystrophies. They are of various types, LGMD1, A to I, and LGMD2, basically A to Z. So it's a very complicated group of disorders with a variable types and different genes involved. In children, typically we see group of LGMDs as sarcoglycanopathies, which are similar to the DMD. Sometimes calpainopathy and LGMD2I. So the main therapy which has been advanced and tried in this condition, where early clinical trials have been tried, are basically the gene replacement therapy. It is considered basically similar to DMD or SMA, where you were trying to repair or replace the faulty genes and with these different vectors. And basically, in the same principle, you have an AAV vector which has the transgene, and you are trying to correct the deficiency of the gene using this. Again, none of those therapies have been approved. We need long-term trials or with a larger number of patients to see whether it would be effective. And lastly, about X-linked myotubular myopathy, which is a form of congenital myopathy, which is X-linked, meaning it's typically seen in males and females are carrier. They present with severe weakness, hypotonia, and respiratory distress within the first year of life. And here, even the gene transfer therapy has been tried and has shown some early promises. Basically, the same principle, you are replacing the faulty gene with a transgene with the hope that it would stabilize the muscle function and prevent the respiratory decline. With that, I would end my talk, and I would be happy to answer some questions. Thank you.
Thank you, Dr. Ghosh. I just wanted to mention that we had a comment through the chat that Lurie Children's in Chicago is getting the Fibrogen trial. So we had a couple people ask about that. Do you know anything about that trial, Dr. Ghosh?
Yes, so a Fibrogen trial is, there are, obviously Boston Children's Hospital is one of the site of the Fibrogen trial. It's basically a phase 2 trial for mainly non-ambulatory patients. Mainly the hope is if it can prevent the decline of respiratory function. So stabilization and prevention of respiratory function is the main motto of this trial. For Duchenne muscular dystrophy, it's basically to prevent the fibrosis or replacement of the muscle tissue by fibrous tissue, and that's where this medicine works. I have not shown that because these are more in the trial phases rather than approved phases, so it's a little difficult to incorporate everything. So that's why I didn't put in that my presentation.
Are you familiar with a clinical trial on exon 44 for DMD?
So that would be another important. So exon 44 would be helpful for patients who are exon skipping. Basically, that would be helpful for patients who are deletion of exon 45. Now, there are, I am personally not aware of any particular trial, but theoretically it would work in the same way of other exon skipping trials. And there are so many different exons and deletion which would be amenable in the similar way. And our hope is if we continue to get this approval, we would be seeing some improvement and introduction of those exon skipping in other patients.
Okay, perfect. I don't see anything else that popped up while you were speaking. So thank you very much, Dr. Ghosh. Thanks for your presentation.
Okay, you're very welcome. Thank